Hi, this is Roen Cacas Ferbolido, and this is basic Ivus interpretation. I have nothing to disclose. This is the outline of my topic. So Ivus is practically looking inside the vessel. So our view is that of a cross-section of the vessel. This imaging modality uses the principle of ultrasound. Now here are the three components of the device system of Ivus: the catheter, where the transducer is, the motor drive unit, or MDU. This rotates the transducer and does automatic pullback. And of course, the console. This is where we assess and measure the image through the monitor. This is the Ivus catheter. Notice the catheter caliber is slender enough to fit in a 5 French guiding cath. It is also important to note that the transducer is actually a few millimeters from the tip and not exactly at the tip of the catheter. There are two types of ultrasound transducer or Ivus transducers. We have the mechanical, which consists of a single transducer element located at the tip of a flexible drive cable housed in a protective sheath. The drive cable rotates the transducer at a very fast rate around the circumference to form the cross-sectional image. Notice the guide wire passes beside the transducer, so you'd be able to see the guide wire in the image. The phased array is made up of 64 fixed transducer elements mounted circumferentially around the shaft of the catheter. The guide wire port is located in the center of the transducer, so you won't be able to see the guide wire in the image. This table is a table of the different Ivus catheters available in the market. Notice they have different ultrasound frequencies, which is significant because with a higher frequency, you would have good resolution of the image. However, the field of the vision is shallower. The lower frequency, on the other hand, will give you a deeper field of vision, sacrificing good resolution. Now, another significant difference here is the distance of the transducer from the tip, from 2.5 millimeters to as far as 20 millimeters. So in cases where you want to evaluate the CTO plaque closest to the tip, it is advisable to use the catheter with the shortest distance. So the Ivus pullback actually shows us a series of multiple cross-sectional images of the vessel. This is what we see in the Ivus. We see the lumen and the vessel wall. Here we see the three layers of the vessel wall. The intima, made of endothelial cells, is hyperechoic. The darker border beyond the intima is the media, which consists of smooth muscle cells. And the outer layer is the hyperechoic adventitia. It is highly echoic because of its high collagen content. In the Ivus, the adventitia is our reference structure for gain comparison, just like what we use in echo. We use the endocardium as a reference point for gain comparison. Let's look at the structures that we see here in a normal vessel from outside to the catheter. The first is the adventitial layer, which is echodense. The second is the media, which is echolucent, followed by the intima, which is echodense. And notice the blood speckling here in the lumen. Now the halo here, the white halo here, is the ring down artifact from the catheter. And the black zone here, called the dead zone, is where your catheter is at. This is a diseased vessel. Let's identify what we see here. We have the dead zone where the catheter is at. We have the wire artifact. So we know that we're using a mechanical transducer here because we see the wire. We see blood speckling, the endothelial border. The area within the endothelial border is the lumen, the medial border, or the EEM, the atheroma, and the outer layer, which is the adventitia. The circle, the black circle here beside our vessel is actually a side branch. And as you further pull back the catheter, you'd be able to appreciate the lumen of the side branch merging with the lumen of the main branch. Ivus does not only help us quantify plaque burden, but it also shows us the distribution and type of plaque. And of course, knowing these information will help us plan our PCI approach. Now, let's look at the different characteristics of plaque. These are fibrotic plaques. They are bright, if not brighter than the adventitia. These plaques are more stable and are found in majority of atherosclerotic lesions. These are soft plaques. They are called soft because of its low echogenicity. This is generally due to high lipid content. These are calcific plaques. Calcium and Ivus are hyperechoic, definitely a lot brighter than the adventitia. It blocks the penetration of ultrasound, therefore there is acoustic shadowing, which means that we only see the leading edge of the calcified lesion. Therefore, unlike OCT, we won't be able to determine the thickness of the calcified lesion with Ivus. And because of the oscillation of the ultrasound between the transducer and the calcium, we can appreciate reverberations. Quantifying calcium in the lesion is by measuring the angle of the calcium arcs. If the calcium is more than 180 degrees, or worse, if we have a napkin ring configuration, it is unlikely that the lesion will respond to simple dilatation with a balloon. Atherectomy at this point may be in order. It is also important to note the location of the calcium, if it's superficial or deep. Deep calcium may not be addressed by rotablation. These are attenuated plaques. They are fatty hypoechoic plaque with deep ultrasound attenuation. These plaques are quite unstable and are highly embolic. Therefore, the chance of no reflow during intervention is high. In fact, some operators use filter wires if they see significant amount of these types of plaques. On the right is just a comparison of the attenuation by a calcium and by the soft plaque here of the attenuated plaque. We have different plaques here. On the left is the stable fibrous plaque. In the middle is an image of a vulnerable plaque. Notice the hypoechoic lipid core and the thin fibrous cap. And here we see where it ruptured. This is a ruptured plaque. So after a pullback of the transducer across the lesion, this is what we see in the monitor. Aside from the cross-sectional view, the machine will also reconstruct a sagittal view of the vessel. Let's try to identify the structures in the sagittal view. The middle structure is the dead zone of the catheter, and around it is the lumen. The hypoechoic border here is the EEM. The structure within the EEM and the border of the lumen is the plaque. And this hyperechoic structure here with acoustic shadowing is calcium. Once we reviewed our pullback, we can now identify the narrowest segment of the lesion. So we just sweep our cursor at that point and measure the minimum lumen area, or MLA. Then we'll look for the proximal and distal reference. These reference are the largest lumen within 10 millimeter proximal and distal to the lesion. But you'd have to make sure that the reference should not have more than 50% of plaque burden. At this point, we can also measure for the lumen area stenosis by subtracting the MLA from the reference lumen area divided by the reference lumen area. Now, here are some basic measurements using Ivus. We can trace the endothelial border. The area within the endothelial border is the lumen. This is the minimum lumen diameter, the maximum lumen diameter. This is the EEM diameter relating to the vessel size. This is the outline of the EEM. And this is the EEM area. The EEM area minus the lumen will give us the plaque area. Plaque burden is then computed by dividing the plaque area over the EEM area. This is the maximum plaque diameter. This is the minimum plaque diameter. We can compute for plaque eccentricity by subtracting the minimum plaque diameter from the maximum plaque diameter divided by the maximum plaque diameter. This is the maximum lumen diameter. This is the minimum lumen diameter. We can compute for the lumen eccentricity by subtracting the minimum lumen diameter from the maximum lumen diameter divided by the maximum lumen diameter. But actually, we rarely do this on a regular PCI. These methods are mainly used for research. Now let's go back to our IVUS pullback. Notice the EEM diameter at the lesion is bigger than the EEM at the reference point. This is so because of positive remodeling. We can compute for the remodeling index by dividing the EEM CSA at the lesion over the average EEM CSA at the reference point. A remodeling index of more than 1.05 is considered positive remodeling. A negative remodeling is less than RI would be less than 0.95. And so this is the reason why we don't use the EEM at the lesion as a guide to our stent size. But rather, we get the EEM diameter of the proximal and distal reference. And the distance between these two will guide us on our stent size. So after stent deployment or after post-dilatation, we will again have another IVUS run. And all throughout the run, we'll check for stent expansion, stent strut malapposition, tissue prolapse, edge dissection, and hematoma. And on the monitor, we will again sweep our cursor at the narrowest stent area to get the minimum stent area and the minimum stent diameter. Now, an adequately expanded stent should give us an MSA of more than 5.5 millimeters square. That is if we're using a drug-eluting stent. We have to consider a bigger MSA to about 6.0 if we're using a bare metal stent. The MSA should also be at least more than 80% of the average reference lumen area. The MLD should at least be more than 90% of the diameter of the distal reference. Now, sometimes due to some irregularities and calcifications in the plaque, we can have a few segments of malapposition. This is acceptable as long as it is less than 1 millimeter in length and the axial distance is less than 0.4 millimeters. Also, a less than 2 millimeter edge dissection limited to the intima with less than 60 degrees involvement can be tolerated. However, an intramural dissection creating a stenosis, especially with limitation of flow, should be addressed. Now, here's an example of a malaposed stent here. And on the right is a well-expanded malaposed stent. Here's an example of a stent edge dissection. This is where the stent is deployed, this area here. Notice a narrowing just proximal to the stent. And an IVUS showed dissection. This is the dissection flap. Here's an example of an intramural hematoma. Notice the two lumens here. Now look at the EEM. Therefore, the lumen here is the true lumen, and this is the false lumen. Notice also the blood speckling within the false lumen. Before I end, I think it is also important to show you some significant image artifacts that may give us inaccuracies in our image interpretation. This poor image here is due to an air bubble in the Ivus catheter. If you have this poor image, this kind of poor image, it is advisable that you remove the catheter from the patient and adequately flush it again outside the patient. This is NURD, or non-uniform rotational distortion. It's brought about by bends in the catheter, especially when you pass through a tortuous lesion, or it could be due to tight hemostasis valve. These are reverberations brought about by bouncing of ultrasound waves between the transducer and a hyperechoic structure like calcium, stents, and of course, guiding catheter. This is a side lobe artifact. It's brought about by bouncing of ultrasound waves. It's a low ultrasound waves between the transducer and the hyperechoic structure. So the significance of which is you might mistaken this for a dissection flap. So it's actually important to sweep the recorded Ivus pullback to follow structures in question. In fact, it is a lot easier to interpret images in real-time Ivus than looking at still pictures like these. So that's about it. Thank you and good day.